So, one of my roles as a fellow in the Department of Investigational Cancer Therapeutics is to really understand early phase clinical trials, the design, what is the rationale behind, designing these innovative trials. So one of the questions we really wanted to ask and present here today is, how does BRAF rechallenge and retreatment actually impact other tumor histologies beyond melanoma? There's a lot of evidence out there, both preclinical and clinical evidence, including trials that have really looked at rechallenging patients with BRAF targeted therapies in melanoma, cutaneous and mucosal melanomas. And there has been improvement in overall responses and survival outcomes. But we wanted to take it one step further and really look at how does that impact other tumor histologies with the BRAF aberrations. And as we all know, recently the FDA approved BRAF targeted therapy in a tumor agnostic fashion last year. So I think this study definitely has a very valid clinical implication in terms of how do we apply this approach in other histologies. So what we decided to do was between 2010 and 2022, we reviewed retrospectively all patients who were part of any clinical trials of standard of care therapies at our center. And we identified 44 patients, and out of these 44 patients, 16 patients were predominantly cutaneous melanomas. The rest of our cohort was 10 patients with colorectal cancer. We also had patients with cholangiocarcinoma, pancreatic adenocarcinoma, and also with cranial nervous system tumors like glioblastomas and anaplastic astrocytomas, ovarian serous carcinomas, and multiple histologies of thyroid cancers with papillary thyroid and anaplastic cancers. So using this very wide, varied tumor histology basket, we decided to ask the question of how does the first RAF inhibitor and rechallenge with the second RAF inhibitor make any difference in terms of the overall outcomes, in terms of response and survival in these patients. So when we looked at that, we looked at also patients who had intervening therapies in between RAF1, which is the first RAF inhibitor, and the second RAF inhibitor. And we found that about more than 80% of patients did receive some intervening therapy that was non-RAF targeted. And usually, since the older part of the first RAF inhibitor patients were already part of the investigational trial, which has currently been approved with dabrafenib, emurafenib, and encorafenib, only 3 patients from that first cohort were actually on an investigational study with the drug that did not eventually get approved. But in our second cohort, the scenario was flipped. We had more patients, with almost 31 patients in the investigational category group, where they were actually on part of a clinical trial that was testing the next generation type of RAF inhibitors. So comparing both those cohorts, in our first cohort where the patient was exposed to a RAF inhibitor, there we saw objective response rate of 36%, where we had 16 patients who either had 3 complete responses and also 13 partial responses. And this was regardless of just melanoma. Even patients with thyroid cancer, colorectal cancer, cholangiocarcinomas, and pancreatic cancers actually developed objective responses. And eventually, these patients also went on to get rechallenged with the RAF2 inhibitor. And here our overall response rate was around 18.1%. And what we saw was that out of those 16 patients who responded, 5 of them actually re-responded as well. And this was very important because there were also 3 patients who had stable disease with our first cohort of patients who were initially exposed to RAF therapy. And these patients actually ended up having a partial response with the rechallenge with RAF2 inhibitor. So even though the duration of response with the RAF1 inhibitor was actually longer, it was around 8.4 months, compared to the duration of response in the RAF2 inhibitor, which was around 2.6 months, at least there was a response that we could reinitiate by rechallenge as well. Also, what we noticed was that the progression-free survival and the overall survival in these patients who were rechallenged, especially in the responders, were about the same with each other. The overall progression-free survival in the RAF1 cohort was around 13.7 months, whereas the PFS in our RAF2 cohort was around 12.1 months. So almost in a similar basis, we were able to extend the treatment and the survival impact of these patients by a year or more when they were rechallenged. And of course, it's important to note that these patients definitely had higher metastatic burden, at least a median of 3 sites when they were exposed to the RAF2 inhibitor compared to 1 site with the RAF1 inhibitor. They also had more cranial disease. About 80% of patients did develop cranial disease when they came to the rechallenge juncture point as well. So what we noticed is we asked the question about, does intervening therapies or does a treatment break matter? But we did not find any difference that was statistically significant. So there were patients who also, about 30% of patients did not receive any intervening therapies and went on to a second RAF2 inhibitor, and we're still able to develop responses that we could see. And so this is, I think, also important because in melanoma, we do know that a treatment break between 3 to 6 months has been shown to be beneficial. But of course, there could be some confounding factors. We're talking about newer generation RAF2 inhibitors. We're also talking about patients who have more poor ECOG status, performance status, and also patients who don't who have a higher burden of disease and which could also contribute. When we looked at some prognostic variables about what could impact responses and survival, we did not find any statistical differences between the response rate with the RAF1 inhibitor or the RAF2 inhibitor. But what we did notice was that when it came to survival, combination therapies, especially when a RAF2 was combined with another agent, this contributed to inferior outcome as well. And also when we compared between standard of care therapy and investigational therapy, we found investigational therapies could also contribute to a worse impact on survival. Some reasons could be that, with investigational agents, we are always going through a dose escalation and then a dose expansion phase. So we may not have actually reached that maximum tolerated dose or that optimal biological dose to be able to cater to that response and that survival. And that could be one of the biggest reasons why we are seeing such a big discrepancy. But overall, when we looked at, the whole picture, most of our paradigm when it comes to treating patients in oncology, we go through an algorithm of management. You have line number 1, 2, 3, 4, 5. But sometimes it's important to also understand that you could probably go back to that first line of therapy or your second line of therapy and rechallenge patients, and you can have benefits like we see here with responses and improving their survival outcomes. So I think this is definitely a paper that hopefully will impact and change the way we practice and allow patients to have more of a extended survival by rechallenging. And one of the things to support that is we also looked at what were the genomic alterations in these patients. So we looked at patients who had pre-existing tumor or liquid next generation sequencing, and then we looked at patients who had them post RAF1 therapy or the RAF2 therapy. And here what we noticed was that we had data for about 14 patients. 9 of them were liquid biopsies and the 5 of them were tumor-based biopsies. And what we noticed is that the persistence of the BRAF V600 aberration actually continued on in spite of 2 rechallenges. Most of the variant allele frequency between the exposure and after rechallenge maintained between 50 to 70%. And I think that's the key here, that BRAF is a big oncogenic driver that can be retargeted again, and you can essentially hopefully reinduce responses and improve your survival outcomes. In terms of other acquired resistance mechanisms, there were 2 patients with colorectal cancer. One of them had a new aberration in APC and EGFR and GNAS, and the other patient developed a CDK4 gain, a MYC gain as well. So it's I think that the next steps is to really try to understand what are these acquired mechanisms of resistance, especially after a rechallenge with therapy, which is a very unknown area at this point. But now that we have the FDA approval for tumor-agnostic fashion with BRAF-targeted agents, I'm sure more studies will come out and validate, what we've found in our studies so far. Hopefully with a larger cohort and with more genomic information that can support rationally designing early phase trials with combinations to target these resistance mechanisms and hopefully reintroduce these drugs to allow more benefit. Yes.